Okay then, our next speaker probably needs no introduction from any. Colin Doherty, consultant neurologist at St James's and the clinical lead for the National Epilepsy Programme, who's going to give us an update on how things stand. Put your hands together please for Dr. Doherty.
Thank you all for the invitation to come and give an update on the programme. So I appreciate the size of the crowd given how lovely the weather is outside. So I've been here, fairly regular visitor to Brainwave meetings to talk about the National Epilepsy Care Programme, and so I will try and summarise a little bit about the initial plans that we had, but I really want to talk specifically about where we are now in terms of the implementation, and then I want to maybe turn it over to you a little bit towards the end so that we can have a bit of interaction about it. So the first thing to say is that we started with a vision. Now, a lot of people will say, that if you have a vision and you don't have a proper plan underpinning that vision, it's usually a major disappointment. But if you have a plan and you don't have a vision, it's an absolute disaster. So the first thing is to have a vision, and this is it's a bit of a mouthful, and there's a lot of meaning behind each of these words. We want to provide the best value care for all people with epilepsy in the right place at the right time, sharing the best information available. And this vision really sort of embodies many, many aspects of the programme, which I'll touch on as we're going through. Now, the drivers for this vision can be summarised in three ways. The first is what we're calling the epilepsy quality measures. So we just made a blanket decision at the start of this programme that we were going to use international best practice to define what it meant to get good epilepsy care from your neurology service. And so there are 8 measures of quality. I won't go through each of these, but very simply things like every patient's entitled to have a diagnosis. Every patient's entitled to have access to the tests which aid in making that diagnosis. Every patient should have a treatment plan. Every patient should be on medicine if they're entitled to, or should be on medicine, they should be on it. Every patient should be given advice about their lifestyle in relation to things like pregnancy, contraception for women, alcohol intake, those kind of things. So all of those measures are embodied in the programme, and our electronic record that I'll talk about has each of these as a mark. Every person who comes in who gets registered on the electronic record will have each of these quality measures addressed. So that's really, I suppose, what we mean by evidence-based care. Okay, so the best international evidence is telling us that if we have these 8 markers of good care, that we're providing the best possible care. The second thing, of course, is infrastructure, which is designating centres where people can get the best care, and I'll talk a little bit about that as well. And of course, this infrastructure is not just about places, but it's about people, it's about trained staff, and this is the thing that costs money. And then finally, but probably the most difficult, is to embody a system of continuous improvement. And again, I will address the difficulties in that, what that actually means a little later in the talk. So at the very beginning of this, about 2 years ago, it was May 2010, Barry White, who's the National Director of Clinical Strategy, called in various groups from chronic disease, from primary care, from surgery, from acute medicine, in total about 30 different programmes of care across the spectrum of Irish healthcare, and asked them, were they up to this challenge? Could they define some quality, access and cost measures? And if we were to define those and we could make a plan around them, that they would help us to deliver. And so from the epilepsy point of view, myself and my colleagues defined quality as making an impact on the mortality and morbidity of epilepsy. So some of the work we've done, or we're about to publish this, shows that up to 130 patients die every year as a direct and indirect result of epilepsy. That's from SUDEP and from status epilepticus and other causes such as accidents. And over the 5 years of the programme, we wanted to put together a programme that would try and save at least 1/3 of those lives. We wanted to increase the prevalence of patients who are seizure-free. So we know that there are about 40,000 people in Ireland with epilepsy. This is a fairly modest goal, but we wanted to increase the number who are free of their attacks completely by about 2,000. So this acknowledges that there are people out there who have the condition, they may be on some form of treatment, may not be appropriate, they may not be in the right dose, but if they get to the right person in the right place, that they get the right information, that we will be able to render them seizure-free. And then finally, to reduce the number of hospital admissions, save on bed days, and reduce readmission rates. All of those are also cost measures, but they are also important quality measures. Hospitals these days have lost their sheen, as everybody will know, from the bastions of healthcare. Many people will know that hospitals now can be dangerous places to be in, and if you stay in hospital too long, you're going to get a complication. So reducing the amount of admissions and reducing hospital stays is a quality measure as well as a cost saver. So we've actually got quite a modest plan here, which is to reduce the length of stay by just 1.1 days, which saves us about 20,000 bed days, believe it or not. That's the amount of people getting admitted with seizures to Irish hospitals. And then reducing the number of admissions by about a quarter. So that means turning people around at the door based on using an integrated pathway, and I'll show you what I mean by that. On the access side, we want to eliminate unnecessary wait times for epilepsy. Many of you will know that in the Irish health system, not just in epilepsy, but right across the board, 12 to 18 month waits for a new appointment with a neurologist are not unusual, and in fact in some places that's still the case. So we would obviously wanted to address that very, very specifically as a point of access, and I'll explain what target we took. And also we wanted to provide 24/7 access to specialist opinion. What we mean by that is that in hospitals that didn't have a neurology service, that they would have access to somebody to talk to 24/7 about advice about managing epilepsy. And then obviously having everyone with epilepsy have timely access to a structured primary care programme. That's been a difficulty in this programme, and there are many reasons for that, but I'll explain that as we come to it. And finally, to reduce the wait time for epilepsy surgery, which any of you who are on the wait list or who've got it will know, again, routinely 18 months to 2 years is the turnaround time waiting to get epilepsy surgery. On the cost side, everybody's been asked to try and investigate drug-saving costs, us no less than other people, and reducing average length of stay is a cost saver. As I said, about 20,000, 19,000 bed days we're trying to save nationally. And then reducing unnecessary investigation and treatment is another form of cost saving. So this is the plan we laid in front of the HSE, in front of Barry White, and he said, okay, well, I will back you if you can deliver that. So this is the programme at a glance, and what I've done here is in brackets I've placed where we are in terms of the implementation of the programme. So the first thing was to establish a network of regional epilepsy centres, 4 adult centres and 2 paediatric. I'll just show you what that looks like and go back to the slide. So this is what the geographic spread of the centres is. In Dublin we have one large centre in the north side of Dublin, which is in Beaumont, and that's the largest centre in this country because it houses the National Epilepsy Surgery Programme as well. We have one centre which is a virtual centre at the moment, which will be the amalgamation of the 2 paediatric hospitals eventually. Don't mention the war, says you. But once the hospitals are amalgamated, we will have one paediatric centre of epilepsy. And then on the south side of Dublin, there is a centre in my own hospital in James's, which will be responsible for Dublin Mid-Leinster. So Beaumont is Dublin North East, James is Dublin Mid-Leinster, and then the paediatric centre covers the 3 northerly regions of Ireland. There's one paediatric centre in the south, covering the south, which is a smaller centre, one adult centre for the south. And in the west, we've divided up the adult centre, just because of the geographical spread, into 2 halves. So we have our team spread across 2 halves. So that's the geographical layout. And all of those centres has been designated. Each of them has a lead epileptologist who's in charge of the centre. The next phase is the development, and this is the core really of the programme, of a nurse-led ambulatory service. So the plan was to have eventually about 27 nurses covering Ireland, all ages, paediatric and adult. And we've already got 17 of these nurses in place. So we've about 2/3 of the nurses in place. We've got 4 awaiting contracts to be signed, and there are 6 left to be interviewed. Now you might say, why haven't we got further in the 2 years? Quite simply, we had a lot of trouble getting interest from the nursing community in this. A lot of people, as you know, ignorance about epilepsy is not just present in the normal community. Even within the health services, a lot of people just don't understand what's required. And asking for nurses to come and train in this, what they see as a very specialised area, was a difficult thing. So if I had my way, we would have interviewed and appointed all of these nurses in the first months of the programme. But it just so happens that now we're in our 4th advertisement for nurses. We're getting them slowly but surely. We're getting the message through, but we still have a lot of trouble getting the message out there that this is an important disorder, and that it's well worthwhile training in it. This is this integrated pathway. I'm going to show you what it looks like. So this is basically a document. It's a piece of paper. Now it will eventually be an electronic piece, but it's a piece of paper which puts the key elements for managing a person coming in with epilepsy in the hands of the emergency room doctors. It may be hard for you to believe, but the standard of care, this is not just in Ireland but worldwide, it's recognised to be extremely low for acute doctors, emergency room doctors and acute physicians, when they come across a seizure, specifically a seizure where the patient's having prolonged seizures, they very rarely make the right decisions. And as I said, that's not just a problem recognised in Ireland, it's worldwide. And so what we've done is we've created a pathway which defines the steps that the doctors need to do, and I'll show you some very interesting data showing how valuable that's been. In fact, I don't know of anywhere in the world that's done this as successfully as we have. We've developed standard operating procedures, 45 in total, for all the things we do in epilepsy. One of the notions about improving the quality of care is to reduce the variation, to make sure that everything is done with the same level of evidence base around the country. And so what we did was, about 2 years ago, the summer of 2010, we got about 50 people, all of whom had a primary responsibility for delivering epilepsy care, and we asked them, what does an excellent epilepsy service look like? And we came up with these 45 pathways for care. And it covers everything from what the GP should say in a referral letter, what the doctor should cover in his first visit, what he should cover in his second visit, what the information the nurse should give to you, how you might interact with Brainwave, how you might interact with any other organisations outside. And those pathways have all been developed, and the plan is over the 5 years of the programme to start using them all routinely. We have about 12 in routine use now. We wanted to expand the pre-surgical programme, so patients who have epilepsy surgery need about a week and a half admission to hospital before surgery, where they get a series of tests done, they get evaluation of the seizure focus, and since about 1982 there's been no investment in that service in Ireland. There were 2 beds specialised for monitoring patients. These were in Beaumont Hospital, so we've expanded that to 6 beds nationally, 4 in Beaumont and 2 in Cork, and those 2 centres now are under construction. The CUH unit is complete, we just need to get the nurses in place, and the Beaumont one is under construction, and we need to populate those with 5 nurses each. So we've to appoint 10 nurses to each for this program. Those 10 nurses will form the backbone of this 24/7 unit that will be available for specialist advice. So if you get admitted to Bantry Hospital and a doctor there doesn't know what to do, that doctor will be able to call a unit, either Cork or Dublin, and get advice 24/7 about what to do. A really key innovation, and which goes back to our vision about sharing the best information, is our national electronic record. Again, this is a worldwide first as far as I know. Nobody has developed a record that's completely viable, has all the important clinical information, and is shareable right across the domain of healthcare. So again, if you go into Bantry Hospital, your information from your neurologist in Letterkenny will be available to the doctor in Bantry, will know exactly what medication you're taking. So this is a web-based tool, and at the moment we've rolled it out. It's being used all on the east of the country in James's and Beaumont. It's been started being unveiled in the west in Limerick and Galway, and has yet to be unveiled in the south and the northwest. But that's really a key innovation factor. Finally, links to Brainwave and other information resources. Brainwave and we have been working together on an information pack for first seizures. I don't know what we have a launch date for that, Mike, but probably within the next 8 or 9 months. And also they've helped us with developing some web-based tools. There's a thing called the Health A to Z that the HEC is going to launch, where you go in and you just put in a word related to your epilepsy, and some explanation will pop up. And Brainwave have helped us develop that. And then that's just this telephone advice line, which I have told you will be embedded in the surgical program. So that'll only happen after the units open. So that's really the program at a glance, and where we are. If you like, the model of care, what we propose to do, or how these centres are supposed to work. This is kind of our health system at a glance. We have large regional centres, large epilepsy centres, Beaumont, James's, CUH. These are large teaching centres that are often associated with a medical school, for instance. And that's where we're basing our regional centre. And the reason for that is that's where we have our neurologists who have who have expertise in epilepsy. So we didn't want to reinvent the wheel. So these kind of places self-selected themselves almost. But the plan is then to deliver the care at this regional centre in the first 2 years and then start to move it out to other hospitals. So for instance, in Dublin Mid Leinster, the centre now we have in James's is delivering care according to the plan in the regional centre. We've already started delivering the care out in Tala, and we have a plan to move to St. Vincent's Hospital in the very near future. So that momentum is moving out. So this is probably where we are in the second level of the model of care on the nursing row. And the plan is finally to expand out to intellectual disability centres, secondary care hospitals, and then indeed primary care centres when we develop proper. And the whole idea would be, again, to move closer and closer to your home.
Just ask Sarah Carroll here.
Is Sarah Carroll here?
Your nurse's appointment.
Sorry. Okay. Again, going back to our vision, delivering care in the right place at the right time is not my idea, it's your idea. What's the right place and the right time for you? And that's the whole idea, is to move the expertise out of these hospitals. I've said time and again at these centres, if there's nobody in these centres in 5 years' time and all the care has been delivered in the community, that'll be a success. If we start building up citadels in our big hospitals of epilepsy centres, then that's wrong. That's not the model we're looking for. So, key performance indicators. So a lot of doctors get nervous when you start talking about these are real kind of business-orientated terms. I didn't know what a key performance indicator was before 2 years ago. But if you're going to talk to the government, you have to talk their language, and this is what they want to know. And it's very simple. The way I view it is, how will we know? Colin, we'll give you these resources and we'll set up these centres and we'll support you and we'll help you recruit these nurses. But how will we know that you're doing what you said you'd do? And so we said, right, that's a very good question. And so we worked on these things, and we have 7 what we call key performance indicators. These are all indications that we're doing, approaching what we said we'd approach. The first thing is that, and this is a real important innovation. This came out from patients, by the way. This wasn't something that came from the community of workers, because we had, at that meeting of 50 people, we had 4 or 5 service users who came and helped us make decisions about what an excellent care service looked like. And patients receiving a telephone call within 10 days of the referral was a key figure that people said, look, I don't really mind the wait, but if I get a phone call from somebody reassuring me after I've had a seizure that I don't need to panic, that maybe it's good time spent is getting some old information from my childhood, from my GP, and gathering that information, I don't mind a little wait, but I need to be reassured. And so that idea of the contacting the patient. So when we receive a referral now, so in one of our centres, for instance, when we receive a referral, a new referral from a GP or from the emergency department, within 10 days, and that's really 7 working days, right? So we just say 10 days to take into account weekends. That person's getting a phone call from our centre saying, okay, what are the issues? And if that person needs to be seen that day, they will. So if we reckon on that phone call that actually this can't wait, then we'll see them immediately. But largely the next one is the key metric for access, which is we're seeing patients, again, in one centre 80% of the time in less than 4 weeks, as soon as we get a new referral. So again, when you think about the old status where you were talking about 18 months to 2 years, I mean, this is a remarkable turnaround. And as I said, 80% in one centre. Being registered on the electronic record is a key performance indicator. Why? Because it embodies those 8 key factors which tell us that patients receiving good care. So you can't be on the EPR without ticking all those boxes. So getting on the electronic record, and in one of our centres, again, not the same one as these two, but in one of the centres, about 90% of our patients are being registered first off on the electronic record. Fourth one is the number of patients seen at nurse-led clinics. All of these nurses, by the way, and I didn't address this in the beginning, the number of nurses per head of population of patients with epilepsy is in or around 1,000 to 1,200. Now that's a very, very good ratio. And these nurses are not just clinical nurse specialists, they're being trained up to advanced nurse practitioner level. These are basically nursing consultants. And at the end of their training, and they're currently undergoing this training, they will have the knowledge and experience to have their own cohorts of patients. You'll be going in saying, I want to see the nurse, I don't want to see that consultant. He's too whatever. I've been seeing him for years. Do you know what I mean? So the idea is that these nurses will have their own clinics, their own patients, and that's absolutely crucial because we're never going to get enough consultants to give the proper cover for the country. There'll always be a need for an experienced neurologist who has an interest in epilepsy for 10 or 15% of the cases that are really difficult. But 80% of the cases who have will be managed by the expertise developed over nursing. So remember, this is to become an advanced nurse practitioner, you need 5 years post-registration experience first of all. So you need to be qualified more than 5 years in nursing, and then you need to have a program of 5 years of training. So it's a very, very, very arduous training schedule. And so these nurses, once they're, and I don't think anywhere in the world has a figure, a ratio of specialists to patients of that level in nursing. So patients seen at nurse-led clinics is going to be an important metric. Finally, reducing the length of stay for patients to less than 3 days, improving, at least reducing the number of times they come back into hospital, and reducing the overall discharge. And what I mean by that is avoiding admission to hospital. So they're the 7 metrics for key performance indicators, and we are delivering on those in certain centres. Just to give you an example, this is our pathway. I talked about this integrated pathway. So a patient comes into the emergency department now in James's Hospital, okay? All of the emergency room doctors pull this chart out and they walk through this chart. Is this a first seizure? If it's a first seizure, here's the potential causes I need to consider. If there's no underlying cause, is it in fact epilepsy? Then they download the integrated pathway. They follow the simple advice. Is the patient awake and alert? Is self-limiting convulsion? Unchanged CAT scan or normal neurologic exam? Then they can go home. And then they're followed up in the rapid access clinic. So this pathway is useless unless there's the capability of following the patient up quickly, and that's where this rapid access service exists. Similarly, if the patient already has established epilepsy and there are recurrent seizures, then they're advised to get in contact with the nurse to download the summary from the electronic record, and again the same algorithm occurs. And just to show you some of the data from this, so we published this in April from that centre. So in 2004 and 2005 in this centre, the average length of stay was between 4 and 5 days. So if you got admitted with a seizure into James's Hospital, the average length of time was about 5 days you were in hospital. And that was a lot of faffing around. You got admitted under some doctor who wasn't a specialist. He didn't really know. He took a day and a half to decide, well, we better get the neurologist called. The neurologist came 12 or 24 hours later. Oh, I think we'll get a test done. That test gets done at day 3 or day 4, and then the decision is you can go home. Okay? What we've done now, when we introduce this pathway, which details exactly what the doctor's to do from time 0 when they come in, we reduce that length of stay to 2 days. Okay? Similarly, when patients were discharged from James's Hospital back in 2004, the average length of time it took them to get a follow-up in the clinic was 16 weeks. Okay, that's been reduced to 4 weeks. And then, this is the most startling one. In 2004, 50% of the time when a patient got admitted to hospital, over the next 12 months, 50% got readmitted. So if you got admitted to hospital, you had a 50% chance you were going to go back in at some point in the next 12 months with the same problem. In other words, nobody really had done anything for you. They just patched you up and sent you on your way. Because we had the pathway and because we were following people up quickly, we reduced the readmission rate by approximately 90%. So patients getting admitted to our hospital now almost never come back in the next year because they get linked into the service immediately. They get a nurse on their case and they manage their issues as an outpatient. So, are we where we expected to be 2 years after the onset of the program? Emphatically no is the answer to that. Okay? Emphatically no. And the reason I'm saying that, well, I've showed you some interesting data because each of those things I've cherry-picked good news stories around the country for little bits of this. We have put in the resources, about 2/3 of the required resources into this program, and we're delivering about 10% of that, of the potential for that. So the question is why? Okay? Now, I am not, let me start off by saying, I am not a Manchester United fan, right? In fact, I can't stand them. But my 9-year-old is a huge fan, and I brought him over to Old Trafford last year for a late season game. Why Manchester United are as good as they are, and why they have been consistently as good as they are, is something that occupies the conversations of Irish pubs round the country interminably. I mean, the passion with which people discuss this question is mind-boggling, okay? And actually, so these figures here, how Manchester City spent 291 million more than Man United. Liverpool has spent 88 million more. Spurs this came from a Manchester United website, of course, where they were showing why you can throw as much money as you like at something, but you're not going to get consistent, high-quality performance. Okay? And that's... Now, I can guarantee you in the pub tonight, that'll be... Some of that stuff, maybe not the figures, but some of those conversations will go on, depending on what the Premiership results from today are. Some of those conversations will go on. I can guarantee you nobody in an Irish pub will be discussing why Irish healthcare can't get its act together. Okay? Why we can't do what Manchester United have done. Okay? And I think that to me is a fundamental problem that I haven't got the answer to. There's a really interesting article in this last week's New England Journal of Medicine. And it said, what business are we in? The emergence of health as the business of healthcare. And it tells us, the author tells us a really interesting story about Kodak. So anybody who's like, less than 25 probably doesn't know what Kodak is. If you're over 25, Kodak was it. Kodak was the company that made photographs. That was it. Everything was done with Kodak. Okay, Kodak is now dead as a company. And the point the author was making was, Kodak thought it was in the business of making photographs. And it invested hugely in the processing of glossy photographs. As soon as digital imaging came in, they had not put no money into the development of digital imaging, and they died a death in the industry. See the point I'm making? They thought they were in the business of making photographs. They weren't. They should have been in the business of making images. And if they thought they were in the business of making images, they would have planned a long time ago for the digital imaging revolution, and they would still be the head of the game. And that's the question in health. We put all this money and all this thing into the delivery of health care. Okay, is that the business we're in, or are we in the business of making you guys have a good quality life? So I heard two very difficult stories here. So these people, in my view, have had a very poor outcome living with epilepsy. Okay. None of this program addresses that. Okay, all the nurses and all the horses and all the king's men and all that will do nothing to fix this problem because it's deeply embedded in our social system. And there was an absolutely staggering statistic in this, which is that in terms of the determinants of outcome, okay, needless death or premature death, okay, healthcare, access to healthcare and the variation of healthcare is only responsible for 10% of that. Let me just say that again so you get this right. Access to healthcare is only responsible for 10% of early mortality. Where you're born, okay, your personal habits, your diet, where you grew up, what side of the tracks you were born, these are all the things which determine whether you will live or die in this country. Okay, they're not healthcare. Okay, so what we need to understand in healthcare, I'm not saying none of this is important. I'm saying we need to understand our place. I need to understand my place in your life. I listened to this story and I don't know how to help you. Now, maybe I should. Maybe this program should embody, the whole social system, not just, epilepsy-specific stuff. And that makes me sad that we've spent all this time planning around this. And actually, here we go. Here's two people, but I can't help them. You can come to my big shiny centre in James's, and I'll say to you, yeah, maybe.
Just before you go on, Edel Montgomery? No. Oh yeah. Okay. Sorry.
So this is the most important slide of today. I'm happy to take questions about where we stand and all the plans and that sort of stuff and the implementation and all this stuff. But this is the most important question. If we're going to have better outcomes, better health for everyone, and I don't mean just your epilepsy, whatever other chronic illnesses you have. If we're going to have better outcomes, and if our performance is going to be better, and this is where I suppose what I've been doing is trying to make the system performance better, putting this integrated pathway in the hands of the emergency room doctors, trying to make the system performance better. And better professional development, developing, doctors who understand these things better, are better trained. All of that is everyone's job. This is my favourite slide of everything I've been doing in the last 2 years. Because you know what it does? It asks the question, what are you going to do? What are you going to do to fix epilepsy? Not just me. Okay? To paraphrase, John F. Kennedy, don't ask what your country can do for you, but what you can do for your country. What are you going to do now that's going to fix epilepsy? You. Have you thought about that question? What?
Raise awareness.
Beg your pardon?
Raise awareness.
Raise awareness. Right. So that's one thing that this Brainwave have done since the 1960s, and absolutely fantastic. And if we didn't have Brainwave doing that at the core face of awareness raising, we wouldn't have it. But you know what? There's loads more than just raising awareness. For instance, if I said to you, centres in Ireland have been given the resources to do these epilepsy things, what's your role in making them deliver? Right, but let's say, do you think it's your role to ask, why aren't you delivering numbers? First of all, where are your numbers? Can you put them up online? Can you be transparent? Can you show me what your admission rates are? Can you show me what your wait times are? And if you're not delivering, but I was told that you had these resources given to you, why aren't you delivering them? Does anybody think it's their role to do that? I think it's your role. I do think it's your role. And it's something that we haven't in the sort of advocacy space. I mean, advocacy has always been, let's hammer the politicians, let's go and say to them, give us more money for this, more, But actually, you know what? What's our role in talking to the people who've been given the resource to do it? You know what I mean? I've got Manchester City and I've got Spurs there, you know what I mean? And I've given them all this shagging money. And they're still, did you see the game last night? Oh my God, the Irish football game. I mean, talk about lack of teamwork, Teamwork, that's one simple concept. Are these guys working as a team? You might recognize this. If you look up duty of care on the internet, right, it's a really interesting thing. This poor gentleman here is an example of somebody to whom you don't owe a duty of care, since he chose to do that. So he's somebody you don't owe. Anybody who chooses to cycle a bicycle like that, you don't owe a duty of care to. But duty of care is something that's culturally defined, okay? And I have a very interesting story. How am I doing for time here? 5 minutes, okay. Just interesting story. In the very beginning of this, when I was, going through the various plans to try and develop this program, I interacted with these kind of management consultant types who were in healthcare, about healthcare system change. And this guy worked for McKinsey, which is a big management company. And he was an English guy. He was married to an Irish woman. And I met him a couple of times. He was talking about, healthcare change. The third time I met him, he had a big black eye. And his nose was all broken this side, and he had stitches going up. I said, oh my God, what happened to you? Oh, skiing in Switzerland, and fell over. Oh, terrible. I said, well, you were in the right place to get fixed, Switzerland, I said, oh no, I got on a plane and I flew to Dublin. Hold on a second. What? He said he flew to Dublin. I said, you need to understand that, I've been around health systems around the world. Don't mix up, by the way, duty of care with quality of care. I think there's a huge need to improve the quality of care in Ireland. But there are very few places that you'll get an improvement in the duty of care. People in Irish hospitals want to get you better. That's not true everywhere, he said. So we're already on the front foot here. We have a healthcare system where the individuals who work in it have a strong sense of the duty of care to deliver care and get people better. So we have the makings of a good team here. I'm not going to have time to go through this in detail, but this is something Leo Tolstoy wrote back in 1906. So Tolstoy could never get over the fact that in Russia, that the Tsars could raise armies from the same village and could make men fight each other who were basically neighbours. He never understood that concept. And somebody from India wrote to him and asked him to give his assessment of what was going on in India. And he said, a commercial company, which is the East India Company, which is established in the 1600s, was basically a commercial company that had political sway over the whole nation of India. Enslaved a nation comprising 200 million people. Tell this to a man free of superstition and he will fail to grasp what these words mean. What does it mean that 30,000 people, not athletes, but rather weak and ordinary people, have enslaved 200 millions of vigorous, clever, capable, freedom-loving people? Do not the figures make it clear that not the English, but the Indians have enslaved themselves? And there is a sense that I think I don't know what the right answer is. I may be rambling here, but I'm trying to get to this notion that the answer here to fixing us is not throwing any more money or resource at this problem. There's a deeply ingrained answer which builds on this duty of care that we already know exists and builds on advocacy, okay? But it's more than that. It's demanding excellence, right? Demanding excellence from the people who deliver care to you. And going in and asking, are you part of the National Epilepsy Care Programme? Oh yeah. And so what's your figures for wait times? Just sort of ask, very polite. Do you think that would get a good mark? Okay, so this is it. It's all about the creation of will. And this to me is we're getting out of the technical zones here into philosophy. I understand that, okay? But the creation of will, to my mind, is the single biggest problem we have. And it's one thing when you go into Old Trafford, and I was amazed by it, walk into Old Trafford, they have no doubt in their minds they are the best in the world. No doubt. And it's screaming at you from the walls of Old Trafford. And you don't create that overnight, okay? And that will is what does it. It's not the money. I mean, obviously there's a certain amount of money and there's a certain amount of talent. But those figures are telling us that you can throw as much money as that, but you don't create that will from money. So I'll just throw that up at the end. This is our regional epilepsy centre. So this is St. James's Hospital. Anybody who knows James's Hospital knows it's got about 15 million acres of high quality healthcare real estate, okay? And this is what they've given us to put the epilepsy centre in. Okay? And you know what I say to them? Thank you for that, okay? Because in 5 years' time it's not going to be there. In 5 years' time we're going to be delivering it everywhere else. And that and that building there does not mean to me that we're not going to be the best. Okay? And every week we go around and we talk about, I ask the nurses, what's your aim for this service? And if they vacillate at all, I say, next person, until somebody says, we're going to be the best epilepsy service in the country. That's it. Thank you.